All right, this is the second half of the kind of video series for our patient who has heart failure. So we've established in the last video that the patient had serious damage to their ventricle that has permanently impaired their ability to maintain cardiac output. So he needed extraordinary measures to kind of get past that very kind of dangerous tipping point where he wasn't supporting perfusion for his body. They supported him with the IABP, and now that he's been more stable, we can jump into what we might do with this patient, and we'll start kind of going head to toe through the PT evaluation process. So because this is kind of going back through the case again and kind of including those elements that you would definitely document in your chart, these are the things we're looking for. He's a 41-year-old English-speaking black male. We've got his height and weight and his BMI range. It's always helpful to have a kind of clinical picture of their physical size for planning in terms of mobility, and always kind of keeping cardiovascular risk factors in mind. Obviously, this is probably one of the factors that might have played into his path to where he is today. So he has been married 18 years. He has a 15-year-old daughter, and relationships are strong. He has been the owner of a building supply company since 2009. He lives in a private 2-story home. He has had occasional panic attacks ever since that myocardial infarction he had early on in his life, so he's been taking Xanax to manage that. He doesn't smoke or have any drug use. He reports about 2 beers a week. He worked full-time until a week ago. He enjoys yard work and family outings. His family history really paints the picture of one of his strongest cardiovascular risk factors. There is a lot of cardiovascular history from a father that died of stroke, a mother with an MI, a brother with an MI at 49, and then a sister who's living after a CABG, and another sister who died of cancer. His personal past medical history is that old myocardial infarction that was treated with a CABG. He had high cholesterol and hypertension. These are his current list of medications. So he's still on a number of drugs to help with pressure support. He's on the heparin. Digoxin is another pressure support drug. He's on the diuretic. Vasotec is an ACE inhibitor. So the goal here is to decrease vasoconstriction in an effort to reduce blood pressure. Coreg is a beta blocker. So he's on a beta blocker to try to reduce his myocardial work through the drop in heart rate and contractility. So these are all drugs that have been brought on board and in an attempt to help control the heart failure and maintain enough support of the heart to perfuse his tissues. So let's say all underlined on your slide, the drugs that are really meant as ionotropic agents, the drugs that help to support contractility. These drugs kind of work through different mechanisms. Dobutamine and dopamine stimulate the beta-1 receptors, which will really support that contractility, where digoxin works through raising intracellular calcium. The calcium obviously would strengthen the contraction because more calcium available allows more actin and myosin cross bridges to form. And I might have mentioned this when we went through it previously, but when you're looking at the meds that are on board, the number of ionotropic agents is significant for the clinical picture. So the more of these that he's taking, kind of the worse shape he is in. So if one of these drugs did the job, they wouldn't have all three. Just something to, this is such a power to really use the medications to inform your knowledge of the patient and kind of their clinical picture. He is on 5 liters of oxygen via nasal cannula. All right, clinical tests. He reached his peak CPK was 2,900. Anything above 1,000 is indicative of the MI. His BNP is 875, evidence of acute decompensation. Serial troponins revealed the damage to the myocyte that has occurred, but because it is trending down, that is a positive sign. Then we can go in and treat this patient. BUN and creatinine are both elevated, kind of suggesting that the kidney experienced some damage when he went kind of into his heart failure crisis. Hemoglobin and hematocrit are both a little low. His chest x-ray revealed pulmonary vascular congestion, so fluid that is backed up into the lungs, bilateral pleural effusions. The EKG shows sinus tachycardia, so his body is really using heart rate to support cardiac output. Left atrial enlargement, very common to see that with the volume overload. There is kind of the EKG scar from the old infarction with some Q waves in leads 2, 3, and AVF. And he still has the evolving anterior infarction. The previous lecture, we talked about the 2D echo that showed anterior septal and apical akinesis, otherwise kind of reduced movement of the ventricular wall, and his ejection fraction is 25%. The cardiac cath showed that the grafts of the anterior descending and circumflex are occluded, but that the posterior descending was intact. The 24-hour thallium scan showed no viability in the anterior septal or apical region. So this patient's vitals is resting at 110, which we mentioned. His blood pressure is 90/60 with all of that pressure support, pharmacological pressure support on board. So they're really supporting his cardiovascular system to kind of maintain the minimum here. You know, he's pretty low. Respiratory rate's 20, and he's satting at 92%. I know Katie talked about it in her lecture, but this is a picture of the Swan. This is what it looks like in real life. You know, if you do a Google images of a Swan catheter, they show it with all the nice catheters kind of laid out so you can see all the different lines that are going into the heart. But in a hospital setting, this is what it looks like. It's just a big mess ball of tubes. And I know she mentioned this, but you don't untangle this. You can just kind of hold the whole thing and support it. But I put this picture on here just to remind you that his vitals are precarious in that his pressure is low with a lot of med support, and he's, you know, kind of driving cardiac output at rest with a higher than normal heart rate. But that Swan is going to give you a ton of real-time information about how this patient is going to tolerate therapy. So it can be nerve-wracking to get a patient up and move them when they're this kind of medically fragile. But the monitoring should give you confidence. That's why I really walked through exactly where that Swan was going and the information that you're getting, because there's no, you know, you will never move a patient with more information than when one that is, you know, just covered in lines in the ICU. So just remember that this is going to be the primary thing you're watching and keeping very close tabs on, obviously in conjunction with his subjective report. But we have the benefit of real-time monitoring of many aspects of his cardiovascular system. Okay, so let's go see him. So he is alert and oriented to person in place. He follows commands slowly. He is very anxious and fearful about moving. Upon inspection, he is diaphoretic at rest and reclining in bed. His integumentary system is intact. So that integumentary system, that's a huge thing that PTs that are in the ICU are always looking, because we can sometimes get the best view of areas of the skin that are hard to see. And this patient is at really high risk for skin breakdown because of the complete lack of mobility. You know, when we're not in there, he hasn't moved yet. So combine that with poor nutritional intake during this crisis, and his skin is a real concern here. He's got an excessive thoracic kyphosis. It could be related to the monitors. Sometimes that's a position of fear. You know, it's a little fetal position, kind of to pull those shoulders forward. So taking in the visible fear is an important thing to choose how you address patients, because you're going to want to really talk them through the expectations, what you're there for, why it's safe, how you're safe, more than that's going to take a lot of time if someone is very worried. So keeping your eye out for that evidence of their state of mind. Chest evaluation, you see a rapid, shallow breathing with a Cheyenne-Stokes respiratory pattern. So we talked about this in one of the very first lectures of the semester, but that is that breathing pattern. It's shown here on the slide for you, where it's a progressively deeper and faster, followed by gradually more shallow until you have a temporary stop or an apnea, and then it picks up again. It's a very common breathing pattern in heart failure. It's not necessarily significant for a clinical decision-making standpoint, but it's unusual for a normal, healthy person. Cough assessment. He's effective at coughing, and he was able to mobilize sputum, which is pink and frothy, about 2 cc's. I just want to step out of the PowerPoint for a second and just address what's going on here. Why would a patient with heart failure be coughing something up? Because sometimes this can be a little confusing given what you know about cardiogenic effusion in the lungs. So here's kind of a chronic heart failure patient. If we draw the single, here we'll put kind of chronic community dwelling heart failure patient. Here is the single alveoli. So we're in the lungs. And the blood vessel going by, that pulmonary capillary. And because of the heart failure, you have increased hydrostatic pressure in the capillary. Because of the increased hydrostatic pressure, fluid is going to leak out of the vessel, right? This is kind of the driving mechanism of why there's fluid in the lungs. So fluid leaks out, but it typically leaks out kind of around the alveoli, because the problem is not in the lung, it's in the blood vessels around it. So that's where you get, if you had the kind of chest x-ray image here, you can get fluid kind of accumulating in the pleural space as it leaks out. So there's fluid kind of around the lung. So this can sound like crackles because of the movement of that fluid. The pressure of the fluid can actually cause some airway collapse. And the fluid on the lung can be irritating and stimulate a cough. So it's common in heart failure to have a non-productive cough. It's non-productive because the fluid is outside of the lung. So when you cough and air moves in and out here, this is not where the fluid is. So what you cough out is non-productive. This patient is coughing up this pink frothy sputum. So let's make we'll divide our screen here so we can stay organized. In severe heart failure, we're going to draw the single alveoli again, and we'll draw the blood vessel going through. But if you're drawing along with me, let's make this blood vessel just bulge with pressure, mainly to illustrate our point. So it's like bulging because there's such a high amount of capillary hydrostatic pressure. And this high pressure allows fluid to leak out, just like we did in the previous slide, but it also will drive fluid into the alveoli. So now you have fluid in the lung, which is what makes the cough productive, because if air is going in and out here, right, this can actually take the fluid along with it. The pink piece is telling you that there's blood in this fluid. So a pink sputum is a sign of some bleeding. The alveolar wall and the cells of the alveola are so delicate that when you have such a high amount of pressure, you can actually get small ruptures at the alveolar capillary membrane and cause bleeding. So because this pressure is so high that at the capillary alveolar junction, you can get cellular damage to the point where you actually get blood in that fluid, and that's where you get the pink frothy production. of a productive cough. So this is a sign. It's a very bad sign. That's if you were a community dwelling heart failure patient and you started coughing up pink frothy sputum, you should seek medical attention, because this is a sign of extremely high pressures in the pulmonary system. So I hope that makes sense. If you were confused at all about how the fluid gets in, it really has to do with the severity of the pressure differences. Okay, back into kind of our documentation of our patient. The appearance of the extremities: he has 3+ bipedal edema 2/3 of the way up the lower leg. So now we also have evidence that the right side of the heart is not handling the congestion well. This crackles that you might hear in the lungs and the cough, productive cough, is all showing the left side backing up, and now we have evidence of the right. So if you listen to the lungs, bibasilar crackles, which is the sound of that fluid moving, and maybe even alveoli that have been collapsed from the pressure around them, kind of popping open on inhalation. Auscultation of the heart reveals regular rhythm. The S1 and S2 is heard a very loud S3, so that's the sound of the filling of the heart when it has a high volume and pressure. That's that ventricular gallop. You can also hear the S4, where the atria contracts into a high volume at low compliance, or that atrial gallop. Okay, it's time for our mini stress test, right? Every PT session is kind of its own little mini stress test, because we're going to do an activity evaluation. We're going to challenge his cardiovascular system and keep a close eye on how well he tolerates it. So these are those resting vitals: blood pressure, heart rate, and oxygen saturation. So you get him sitting edge of bed, and his pressure drops and his heart rate goes up. So this is, it's good to see the heart rate respond. So his body is recognizing that the pressure is down. So let's give him a little support here. Have him sitting edge of bed, doing some knee extension, trying to facilitate getting that blood back to the heart and activating his sympathetic nervous system a little bit. And you can see his pressure kick up just a little bit, 84/60. You would check in, see how he's feeling. He says, I feel pretty good. He's not dizzy. Let's try standing. So we get our patient standing up, and the pressure falls even more. The heart rate does still creep up a little higher. So his body's trying to fix the problem and responding to the strain or the exertion. But this is also a pretty dangerously low drop here. So at this point, you would get the patient to bed and start monitoring the recovery. So once he sits down, his pressures start to creep back up, and you'd monitor him until he fully recovers, and make a decision on whether or not he could stay in the chair or if you would have to return him to bed. So how you would document these results is that the patient had resting tachycardia consistent with pump failure and deconditioning. He experienced mild postural hypotension consistent with orthostasis. He saw an appropriate increase in heart rate and blood pressure with low-level exercise. So that's a really good finding at this point, that he was able to kick that pressure up with a little bit of those knee extensions. During the stress, he still had sinus tachycardia, no ectopy observed during a session. That means like there were no PVCs thrown, kind of evidence of cardiac irritability. The static standing, he had balance but required contact guard. Dynamic standing balance required minimal assist. Gait was not assessed at this time due to hypotension in standing and the risk of dislodging the Swan-Ganz catheter, and patient denied any chest pain. So our diagnosis: the patient is a 41-year-old male with primary impairments in aerobic capacity and endurance, and ventilation and respiration associated with cardiovascular pump failure. Additionally, he has secondary impairments in gait and balance. So what would we kind of set for PT goals for a patient like this? He would be seen daily until he is an independent ambulator, and then reduced progressively until all goals are achieved. So what we're hoping is in 2 weeks that he will be independent in diaphragmatic breathing and cough, kind of managing those secretions that are in the lungs. Patient will be independent with gentle, active range of motion exercises. He will be able to transfer supine to sit with just close supervision. He will be independent for static sitting balance. He will require close supervision for, my phone is going crazy right now, warning me about some weather event, but it looks very nice outside the day that I'm recording this. So I'm going to mute my weather events. So if this recording, you hear me like screaming because a tornado is heading for my house, like, I guess it's too late. You'll just know what happened to me then. Just kidding. Okay, where was I? Patient will require close supervision for stand pivot transfers and will tolerate 5 minutes of cycloergometry with no or minimal tension from a position seated in a bedside chair. So these are very achievable goals, realistic goals, and all would be working towards, progressively moving him into a mobility plan. Long-term goals, 8 to 16 weeks, he would be independent in self-care. He'll be independent in ambulation on level surfaces and 1 to 2 flights of stairs. Patient will demonstrate a maximal strength and aerobic capacity within the constraints of his disease impairment, functional limitations, and disability. Okay, 8 days after admission, the Swan-Ganz catheter was removed and the patient was transferred to the cardiac telemetry floor. So this is a positive finding. He was stable enough that they didn't need that extreme monitoring anymore. At transfer, his hemoglobin and hematocrit are a little better. BUN and creatinine are trending down. I can put the original ones up here. All positive findings. At this time, you administer the 6-minute walk test. The 6-minute walk test is really a preferred functional exercise capacity test. It's really big in the pulmonary setting, but in the cardiovascular units as well. And that might really bother the exercise physiology majors, or those that really, know a lot about maximal exercise capacity tests, because a 6-minute walk test is a sub-maximal test. Patients have a self-selected intensity. Patients are allowed to stop and rest. But it is an objective evaluation of a functional exercise capacity, the walk, and it correlates well with measures of quality of life. And changes in the 6-minute walk test correlate with subjective improvement in dyspnea. So because it is such an objective, reliable, easily reproducible test, and it has these nice correlations to improvements in the factors in their life that really matter to us, it can be really helpful. It's nice to have this kind of in record of where they are, because you can use this to show improvement after an intervention, to document the impact that your therapy had on a patient. So this is the data from his 6-minute walk test. You can see he walked 75 meters. The average for a patient with heart failure in his age range is around 310 to 427 meters. So, and then an age-matched healthy control would be like 590, just to put that number in context of just how debilitated this patient is. His maximal heart rate during the test got up to 132. His blood pressure, the lowest point was 84/70. His rating of perceived, his RPP, his rating as rate pressure product. That's where you take the heart rate times the systolic blood pressure, and can be really helpful to know kind of the ceiling of their limit. The maximal rate pressure product was 11. His saturation got as low as 89, and his RPE on a 0 to 10 was a 5 during the test. So you're able to increase the patient's activities, but he consistently complains of increased dyspnea and fatigue. As you are walking the patient, you take his blood pressure and observe a decrease in pressure, and the patient loses consciousness shortly after. Patients treated with dobutamine but remained hypotensive and was transferred back to the cardiac intense unit. So this patient is decompensating again, that he'd been progressing, and now his heart is just failing to keep up. So they added another inotropic agent, milrinone, kind of into the mix. Milrinone is almost exclusively used with heart failure patients. It functions to increase contractility and reduce pulmonary vascular resistance. I don't really think this is a drug that you need to know too much about. It works as a phosphodiesterase inhibitor, which means it increases the amount of cyclic AMP in the cell. You don't have to write this down. This is not going to be on a test in my class, but just if you've heard it, I don't know if you guys hit that drug in pharm, but just as kind of a reminder. So cyclic AMP is a cell signaler that's involved in muscle contraction. So that's how it does its work, by trying to increase the cell signal telling the heart to contract. All right, so they added this drug, but he continued to be hemodynamically unstable, meaning he could not maintain his pressures. He was evaluated for a left ventricular assistive device, or an LVAD, in order to have that implanted, which they did on December 7th. So let's talk about LVADs. All right, so these are some images of some of the most common brands of left ventricular assist devices. And I can't even look at this slide anymore without sort of laughing from previous years with senior farewells, because there was some senior farewell where they were like having somebody be like this heartbreaker, like breaking a heart. And I was just like telling them not to worry because you can put an LVAD in, and it was like some pre-recorded video with me just claiming you can heal a broken heart with an LVAD. So that helps you study in some weird way. It certainly makes me laugh and makes me kind of miss all of our in-person antics. But okay, so these are the devices. It is a mechanical device that augments the pumping ability of the heart. That's the purpose of the LVAD. The components you can see in the kind of diagram schematic on the slide here. There is the prosthetic left ventricle. So this is the pump that is implanted into the abdominal wall, or sometimes the peritoneal cavity, kind of that space between the abdominal wall and internal organs. It is either an air pump, like a pneumatic pump, or a battery-powered pump that does the kind of energy work of the heart. You have the inflow cannula. And the inflow cannula is connected directly to the apex of the left ventricle. And then the outflow cannula is connected to the ascending aorta. Okay? So the blood enters the heart normally and then goes into the inflow cannula, is pumped by the LVAD pump, and then that powered flowing blood is returned into the peripheral circulation via the aorta. So the main goals here are primarily to use this as a bridge to transplant. So this guy his native heart was insufficient to keep him alive long enough to receive his heart. But this device can do the pumping for him, so he can kind of keep him alive until a heart becomes available. This can sometimes be used as a bridge to recovery, meaning by just giving the heart a break and letting the LVAD do the work, the heart has some time to heal, and people actually get off of this device and their native heart kind of returns to its original job. This has somewhat recently been approved as a destination therapy, meaning this is it. Like, this is the treatment they're going to get. Maybe the patient is not appropriate for transplant for whatever reason. So they're never going to get a transplant, but they wouldn't have been able to live without it. They get the LVAD to, be able to live as long as possible, given everything going on. So the reason that the LVAD is able to accomplish these goals is that the pump unloads the heart. So this device, because it's doing the pumping for the heart, decreases myocardial work. It also has the ability to maximize subendocardial perfusion. So the heart is the pump to itself. So when the heart is failing and it can't generate enough pressure, to maintain a good cardiac output, that means there's less driving pressure in the coronary vessels. So as the heart gets weaker, the blood flow to the heart gets worse, which makes the heart get weaker, which means the blood flow gets worse, kind of around and around you go. This is one of those vicious cycles where the problem makes itself worse and you kind of spiral downward. With this device, even though the heart is very sick, you can pump a lot of blood into the coronary vessel so that while the heart is healing, it's getting really good blood flow. So while this device looks kind of scary and intense, it is safe and effective to do PT when someone has an LVAD. I mean, some of these patients are being discharged to home with these, so they need to be able to do all the same, mobility goals as anybody else, just with this device. So they need to be able to gain independence in their ADLs and gait. You want to maximize strength, flexibility, and endurance while they're in this device, whether it's to get them ready for a transplant or to have them have the most, enjoyable quality of life as possible. It's kind of the same goals as any other patient. So some things to notice on the kind of the screen of the LVAD, like what these numbers all mean to you, kind of in the context of normal cardiac function. So I have them listed in your notes here. So pump flow is a number that you can see on the screen, and it largely equates to cardiac output. So it's an estimate based on the pump speed and the power that the unit is using to drive the blood, gives it an estimate of cardiac output, kind of. Pump speed is something that's set by the team that has put this device in. It's set according to the echo results. So that's really not something that we look at or touch. I mean, we don't touch any of this stuff, but it doesn't impact us really at all. It's just a fixed speed. The pulsatile index, though, is probably the most important one. This one shows you how much cardiac output is being provided by the patient versus the pump. Okay, so this is the index. Basically, if it's a really high number, that would indicate that there's more ventricular filling. So the pump is providing less support. A very low value means that there's less ventricular filling and the pump is greatly controlling, it's supporting the cardiac output. The pump's doing the work. So a low pulse index tells you that the pump is doing more. And then pump power is the measure of the motor voltage and current consumption. And this will change with it changes in speed and flow. It can also change with physiological demand. So when we come in and, challenge their physiology to do mobility and gait, it can affect the pump power. If you would see this number just sort of gradually creeping up, that can be an indication that there's like a clot in the pump. So it would be abnormal to just see it kind of steadily rising. If there's any abrupt changes to the pump power, that should be evaluated. You should have someone come and look at that. All right, some clinical features of patients on an LVAD, things that are a little different when they have one. It can be very difficult to hear anything with heart auscultation because as soon as you put a stethoscope on, you just hear the noise of the device, the running noise of the device. So it can make it kind of ineffective to do auscultation. What can be strange if you're not used to treating these patients is that many of these patients are pulseless because we don't have the highs and lows of systole and diastole. The LVAD is a continuous flow device. So because of that, especially if they have a low pulsatility index, meaning that the pump is doing most of the work, there might not really be ever a time when it's higher enough to pick up a pulse. So that can be a little alarming because it's sort of, since you figured out there was a pulse, it's like the reason you know someone's alive. So you go to feel their pulse and they don't have one. The EKG The heart rate that's on the EKG can sometimes differ from the pulse rate, if you can even feel it, because the machine is not synchronized with the native heart. So sometimes that can be kind of odd. Those don't match up. So they may or may not have systolic and diastolic blood pressure for the reasons already described. So when you are monitoring these patients or you're documenting, once they're on an LVAD, you really only use mean arterial pressure. And they should stay between 70 and 100 millimeters of mercury. So after the LVAD is put in, the main goal is, just like kind of any surgery, is just trying to prevent the ill effects of immobility. This patient is going to be on a lot of vasopressive agents just to create hemodynamic stability. But as soon as they are hemodynamically stable, we want to get these patients up and get them moving. So common interventions would be airway clearance, because you cut into the chest, the lungs have the chance of getting pneumonias and be affected. Upright positioning, active range of motion, bedside functional training, and gait training. There's also a bit of education required for the battery management that we as PTs do have a role in, kind of talking them through and having them practice, put it in, put it out, that kind of thing. So this is included in your notes just to kind of see a typical SOAP note from a patient like this. So this is just an example so you can kind of see how this documentation looks. So this is post-op day 5. The patient complains of incisional pain is the subjective comment here. Here's our objective data. They're on 4 liters of oxygen, and we're kind of listing all of their, the devices and drugs. Telemetry, Foley, they're getting IV, dobutamine, dopamine, and milrinone. So still a lot of vasopressive agents. Afibral, the coronary, the heart assessment is obscured by the LVAD, so you can't hear the heart. The lungs have basilar crackles. So the treatment for this day was they went supine to sitting with contact guard. They worked on some diaphragmatic breathing and splinted cough. So again, that splinted cough is going to help the patient get a more forceful cough by holding a pillow to the incision. By kind of keeping the 2 parts of the incision held together, it will be less pain and they'll get a better cough. And it's very important that they're clearing their lungs. Any normal patient, but then in heart failure, you have all this extra fluid as well. So it's just the breathing stuff in these heart patients is incredibly important. Sit to stand with contact guard assist, ambulate 25 feet with a rolled walker with contact guard, and you can record the vitals, kind of the LVAD recordings with each of these activities. All right, so your assessment is the patient had mild dyspnea on exertion, transient dizziness upon standing, mild postural hypotension, appropriate responses to activity, which you can see above. The patient was able to handle the strain. They were able to increase their blood pressure to ambulation. This is a really good sign in a cardiac patient. They're responding appropriately to the exercise stimulus. The patient had normal sinus rhythm. The short-term goals are to mobilize and clear secretions, don and doff batteries with mod assist, supine to sitting with close supervision, sitting to standing with close supervision, and ambulate 50 feet times 2 with a rolling walker and close supervision. So the plan, airway clearance techniques, more education on the battery, and then working on bed mobility transfers and gait training. So it's both nice and maybe not surprising, I guess, but it's nice that it just comes back to the bread and butter of PT. And even though these patients are receiving amazing technologies of medical care and like what we are capable, I love when I say we, as if I was somehow involved in the development of these, but it's the royal we, we're all the medical team. What the medical community can do to support these patients, but then we come in and we really are back to the basics, using what we know about exercise physiology and monitoring vitals and getting the mobility for these patients so that they can be as healthy as possible and get home safely. So I just have one slide in here on the artificial heart. It's not very common at this point, but they do them at Froedtert. I think they've had maybe 4 or 5 now done at Frater at Artificial Hearts. It's an implanted prosthetic device. It's about the size of an orange. So if you're looking at this, it's kind of hard to get the size context, but they really have gotten quite small, that this is supported with this external device here, but it really just completely replaces the native heart, and is a completely synthetic prosthetic device. Really, really cool. All right, let's just talk a little bit about some of the criteria that differentiates cardiac dysfunction from cardiac failure. So for cardiac dysfunction, the heart is not working normally, but you're still maintaining sufficient cardiac output. So you need an ejection fraction greater than 40 for adequate cardiac performance. So if you are above 40, you are, if you are above 40 and still below normal, you have dysfunction, but not yet failure. And there's a range there because we'll kind of go through what constitutes failure. And if you're symptomatic, you might be in the 30s and actually be in failure. There's some variability there when you're in that range. The most common cause for cardiac dysfunction is a myocardial infarction. So the heart is damaged by the MI and it can't return to a strong enough ejection fraction, and it can cause problems. So angina and myocardial ischemia, the ischemia can actually result from the pump dysfunction, because if your pump isn't working well enough, you can't get the blood flow to the heart, and this is often why patients will progress to heart failure, because I already mentioned this, but as the cardiac output gets worse, the perfusion of the heart gets worse and the heart gets sicker. So it's really common when somebody has cardiac dysfunction to see evidence like ST segment depression and arrhythmias. If you see those things, you still ask your same basic 4 questions every time you see an arrhythmia. And if it's a new finding, it's still significant. You don't just, oh, well, they have dysfunction, so I'm not surprised. You still react normally, but it is a common thing seen together. So you can have a lot of cardiac arrhythmias. Arrhythmias do not need to be life-threatening to still impede cardiac performance. So a patient might have an atrial fibrillation that actually causes cardiac dysfunction because it is compromising the ability to get enough blood out in the ejection fraction. MI we talked about. Hypertension can lead to cardiac dysfunction because the heart is just constantly pumping against a load. So that can, lead to hypertrophy, which would shrink the ventricle size, leading to diastolic dysfunction. Over time, the backup of fluid in response to this high blood pressure can stretch and weaken the wall of the heart, kind of leading to a systolic dysfunction. But in general, when somebody has this reduced ejection fraction, you do see some effect to exercise tolerance. They typically have some disability where kind of it's on a spectrum, right? As your cardiac dysfunction becomes worse, it's going to affect your ability to move more and more. So a mild to modest effect on quality of life when someone is in dysfunction. Significantly more disability and quality of life impairment once they go into full failure. So dysfunction in many cases precedes failure, but they are clinically different because they are still maintaining enough ejection fraction to perfuse. In cardiac failure, ejection fraction is less than 30 to 40%. And now we're seeing the symptoms of this, the evidence of cardiac failure. So pulmonary edema and crackles. Now this is going to, kind of all the symptoms we've already gone through. The failure to pump blood forward leads to dyspnea and fatigue. The dyspnea is also related to the pulmonary edema. They can get tachypnic breathing patterns. They can end up with that paroxysmal nocturnal dyspnea when they lay flat. and go to sleep at night, the fluid kind of redistributes and they get a lot of fluid going back to the heart. And that can it's hard on a failing heart to have a lot more volume to deal with. So they can have a lot of dyspnea. So orthopnea is when you have the dyspnea kind of just laying flat, and then the proximal nocturnal is when it happens at sleep. And that kind of pairs with the lower sympathetic output when you're sleeping. So these are all, the classic signs of heart failure: peripheral edema, jugular vein distension, weight gain. In the clinical world, their weight is tracked very closely as a means of keeping track of their fluid accumulation. The liver can get enlarged. It's common to hear S3 heart sounds, sinus tachycardia as the heart's trying to make up for cardiac output with rate. Once they're in failure, they're going to have a marked reduction in exercise tolerance. And you can see abnormal blood pressure responses to exercise. So like instead of going up, systolic goes down, diastolic can rise. The abnormal responses, unexpected responses. So for PT, it's important to be appreciative of these differences because you might actually treat these patients different. So in dysfunction, exercise is good. It's beneficial. They can tolerate daily, even high intensity exercise. At this point, the heart doesn't have a great ejection fraction, but since they aren't failing, they haven't yet kicked in all those physiological adaptations to hold on to a ton of fluid. The only reason that you become so weighted down with extra fluid and failure is because the inappropriate perfusion pressure, like to the kidney, for example, is triggering the renin-angiotensin system to hold on to fluid. So in dysfunction, you don't have all this fluid. So a big difference is that when you're in dysfunction, anything that would increase venous return should help the heart. So when you're in dysfunction, because the heart has a low ejection fraction, and if you guys know, your basic cardiac physiology, if you increase the venous return, if there's more blood going back to the heart, then there'll be more blood to pump. So if you can increase venous return, you can improve cardiac output. So any exercise, two-legged cycling, anything that's like whole body, really dynamic, get that blood going back to the heart, they will tolerate that much better. They can do moderate progressive strengthening. These patients do benefit from inspiratory muscle training and even expiratory muscle training at the level of dysfunction. Once they're in failure, exercise is still safe and appropriate, but they're going to have to do it at much lower intensities and less often. And this venous return piece is very different. And this was addressed in the discussion section for the cardiac unit. So if you're listening to this prior to hearing the discussion, we're going to talk more about this. But a failing heart is in volume overload, way too much fluid in the system. And that heart is stretched out and engorged, and it's already weak because it's in failure. So anything that can reduce venous return, let the heart kind of come back to a better resting alignment, a better length tension alignment of its muscle fibers. Less venous return in heart failure actually contributes to an increase in cardiac output because the ventricle can squeeze more. So in heart failure, they have all this volume overload. So volume is not the problem, and volume is not going to fix the problem. And actually, if you can unstretch the heart can beat better. So if you want to do exercise with the lower extremity, if you do like one-legged cycling, you can get the benefit of that leg and then, obviously rotate legs with less venous returns. They might actually be able to exercise longer than if you just popped them on and had both legs going and you had a bigger venous return. They might end up failing that exercise sooner. So, it's all about, trying to get the minutes, accumulate the minutes of exercise for the benefits that would give the patient. So it's just one kind of trick to do that. You can do strengthening, but very gently progressive. And then they can do inspiratory or expiratory muscle training, but at a lower intensity. Then I just threw up on the bottom of the screen here just an example of an inpatient exercise training program. I think sometimes I definitely stay much more theoretical than in the doing of it. And I know sometimes the students are kind of like, okay, what does it actually look like when we do it? So I stuck this on there, a typical exercise training program. You'd work on some flexibility, do some cycle ergometry, 50 to 70% of peak work rate. Maybe do some treadmill walking for 30 minutes. They can do intervals of walking to accumulate those minutes. They don't have to do that straight through. So just trying to get the minutes in over the course of the day if necessary. You can exercise, the heart failure patients do need to exercise less often. So this type of an exercise training program, they would maybe do 3 to 5 days a week. Where you're really trying to get the benefits of exercise. You're going to need a little bit more rest time in between for these patients. So what do you monitor in a patient with heart failure? Any symptoms of cardiac insufficiency, any evidence that they are not tolerating it. So kind of those abnormal blood pressure responses, fluid accumulating in the lower extremities, crackles in the lungs, productive cough. Those are all poor signs of how the heart is tolerating it. If you listen to the heart and you didn't hear an S3 and now an S3 appears, abnormal dyspnea, shortness of breath, subjective reports of not tolerating it, be very, very mindful that we are working a failing heart and for signs that it's not keeping up. So, checking the heart rate and the rhythm is very important. Knowing what their kind of trending normal blood pressures are and then taking them both in supine and standing. Looking at their jugular vein to notice distension or even measuring jugular vein distension. Like I just mentioned, listening to the heart and lungs and assessing that edema, all really important. So I hope that from this talk and pathophysiology, you can see that exercise is safe for these patients when monitored appropriately. But I think it's important to really understand why exercise works. It really takes us beyond, that makes us exercise specialists, that when we can ourselves know the physiology of why what we're doing works, but it also increases our power when we are able to really explain it to our patients in a way that they can buy in and kind of break this down for them. So the figure that's on the slide here, and I made a version of it in your chart, in your notes, is the muscle hypothesis of chronic heart failure. And central, basically, to this whole idea is the role of skeletal muscle. And it is hypothesized that the reduction in peripheral blood to skeletal muscle is an absolutely critical piece to the vicious cycle of heart failure. So the left ventricular dysfunction is on top, right? That's our disease. Our ventricle has been damaged and it's not maintaining proper blood flow. But because of that, we're not delivering blood flow to our skeletal muscle. I mean, among many other places, but we're focusing on the central concept here. When the muscle is not getting enough blood flow, it actually triggers a catabolic state. It stimulates skeletal muscle catabolism or skeletal muscle breakdown. So because of the failure to give enough blood flow, skeletal muscle is, protein is a very expensive tissue in our body. And if we're not using it, we're going to break it down. If we can't feed it appropriately, and I'm doing air quotes because you guys can't even see me, but I'm still doing air quotes because I talk with my hands Even when I'm recording videos, you never see me. You're missing so much hand talking, this entire semester in these lectures. Air quotes, we're not feeding it with blood flow and oxygen. It's going to stimulate the processes to start breaking it down because our body wants to, save the animal at the expense of the tissue kind of thing. So when you start breaking down skeletal muscle, you end up having skeletal muscle myopathy. So this catabolic state is going to lead to skeletal muscle myopathy, as well as the muscles of the pulmonary system, the muscles responsible for breathing, are going to start to break down. So this causes symptoms that you guys would already guess. If you're breaking down skeletal muscle, you're absolutely going to have more skeletal muscle fatigue. That's kind of outside of the cycle, but helps to explain the symptom. You're going to be experiencing dyspnea as you aren't delivering enough oxygen to skeletal muscles. There's going to be feedback loops, as well as the direct effect on the myopathy to the muscles controlling breathing. But the big piece here that leads into how this facilitates the downward cycle of heart failure is when you have skeletal muscle myopathy, you're going to have increased feedback from those group 3 and group 4 afferents in the muscle. They are going to be sensing that they're working harder to the same job, and you're going to be accumulating more metabolic waste with poor blood flow. So I almost wanted like a dotted line here, right? Like the less blood flow, if you have decreased oxygen and, decreased clearing of all the waste products, that will directly lead to an accumulation of metabolic waste, which is going to stimulate, they call them ergoreceptor activity. We've always talked about them as group 3 and group 4 afferents, which is how I put it on your slide. So that all by itself is going to increase ventilation, which you can see as a sign or a symptom associated with heart failure. But group 3 and group 4 afferents are going to feed back, to the brain and say, the muscles aren't getting enough. They're working harder and they're not clearing out their waste product. We need to stimulate the cardiovascular system to deliver more blood, which sounds like a good idea, except to do that, we are going to stimulate the sympathetic nervous system. And what does sympathetic nervous system do to blood vessels? It causes vasoconstriction. And in theory, this could stimulate the heart. The sympathetic nervous system would trigger increased heart rate and contractility, but this is a dysfunctional heart. So it might not be able to mount as much of a response with the heart, but the blood vessels are going to vasoconstrict just fine. So if you get a big sympathetic output, you're going to get kind of all over the body peripheral vasoconstriction. If you vasoconstrict the arteries, that is going to increase the afterload on the heart. So now you have a higher resistance to cardiac output, which is going to worsen the left ventricular dysfunction. And the reason it's a cycle is because the vasoconstriction is also going to worsen the peripheral blood flow. So like with any vicious cycle, you start going around and around. Less blood flow, more catabolism, more skeletal muscle loss, more type 3 and 4, even more sympathetic activation, even more vasoconstriction, worse left ventricular dysfunction, and around we go. So in this way, you can see how skeletal muscle can play a central role in the worsening of the cardiovascular pump if not managed or treated. So I'm ending this heart failure talk on a huge ending on a high note. Properly prescribed exercise is a key modality that has been applied to manage and improve heart failure for these exact reasons. If you can stimulate skeletal muscles with exercise, you can prevent the myopathy. If you prevent the myopathy, You have a significant impact on the degree to which the receptors are feeding back, which means less sympathetic output, and you can lower afterload on the heart. So exercise can interrupt a key step in this vicious cycle and can slow the progress of heart failure because it plays a critical role in the deterioration of left ventricular dysfunction, or deterioration of left ventricular function, I suppose I should say. So we have an exciting role to play. At this point, most of you probably know where you're going in your lives and your careers, but just a little plug. If you get jazzed up about exercise physiology, there is nowhere in physical therapy practice where exercise physiology isn't more put into practice to make a huge impact in people's lives than in the cardiopulmonary setting. We really get to exploit exercise for what it has the potential to do in diseases where there's very little hope. But we can come in and we can really make life better. We can improve quality of life, and in this case, actually affect the disease progression. PTs are totally awesome. All right. Have a wonderful day.